Good afternoon, everybody, and good morning for those of you who are not on the East Coast. My name is Ashish Chan. I'm the Dean of the School of Public Health at Brown University, and welcome to the 21st annual Dr. and Mrs. Fred Barnes Lecture in Public Health during National Public Health Week. For a little bit of housekeeping, first of all, and then I'm going to talk a little bit about this lectureship, and then I will introduce today's guest lecturer. So in terms of housekeeping, this is being broadcast live on YouTube, and it will be recorded, and it will be playing. It'll be available on our website and other websites related to National Public Health Week later in the day. So it is being recorded. Today's conversation with Dr. Paul Farmer will be a discussion between me and Paul, but I would welcome all of you to send in questions through the Q&A feature of the webinar. Let me tell you a little bit about the Barnes Lecture and why it is such a special lecture for us at the School of Public Health and at Brown University. This lectureship is named in honor of Dr. Frederick Barnes, who came initially to Brown University in 1962 as the founding faculty member of a new program in medicine. And he developed this program really to teach undergraduates and to get undergraduates excited about biology, about public health, about medicine, and taught a wildly popular course called The Informative Way of Life. And one of his students, Jim Zissin from class of 74, endowed the lectureship because he viewed Dr. Barnes as a quintessential physician scholar that he was. And so I am really grateful for both the Zissin family and the Barnes family who are here today for the lectureship. This is really the highlight for us of the National Public Health Week. And what better way to celebrate this event, this wonderful event, than to have today's speaker. And I'm not going to spend a lot of time introducing Paul Farmer because there are very few people in public health who need an introduction less than Paul Farmer. Everybody knows Paul. He is the founder of PIH, Partners in Health. He is a physician. He's an anthropologist. He is a Kolokotrones University professor at Harvard. And there are just a large number of us out there in public health who see Paul as a mentor, as a guide, as a North Star, and as a friend. And Paul has been all of those things, certainly for me. And so it's hard to be more excited than I am today having Paul Farmer here as our Barnes lecturer. So let me see if we can get Paul to join us. There he is, Dr. Paul Farmer coming in from Miami today. Paul, thank you for being here for the Barnes lecture. As I said, I really am just absolutely delighted to have you here and looking forward to our conversation today.
It's an honor and a pleasure. So thank you, Ashish.
Well, Paul, I want to get us started since we're going to do this as a conversation. And I want to get us started with a really straightforward question that I have learned to ask by watching you. One of the things that you push all of us to do is ask the question, why are things the way they are? Not to presume that they have to be that way, not to presume that there can be no other way but the way they are, but to ask, why are they the way they are? And with that as a starting point, I'm wondering if you could talk to us about the moment we're in right now. Look at the pandemic, 14, 15 months into this pandemic. And just begin by giving us some reflections on how you think this pandemic has played out and why. Why has it played out the way it has? And maybe from there, we can launch into a bunch of specific things. But if you don't mind, let's start at the top. Here we are, 15 months into this pandemic. How has it gone in your mind and why?
Well, I think that we can agree that, if just to adopt, as we always do, the nation state as a framework, we do that too quickly also to adopt that framework. But speaking as an American, I'm aware that most of us think we've done uniquely poorly. And, since the body count is always a necessary way of reflecting on how well we've done, we're facing still just an enormous amount of loss. And that qualifies us for not a great grade in looking at the U.S. response. And I don't feel that among the many clinicians and public health figures that I know, that they have done a uniquely poorly job at all. I mean, you don't look at American medicine and public health and say, "Wow, Tony Fauci has done a poor job," or American vaccinologists, or even, the pharma companies that have worked on the vaccine. They haven't done a bad job. And then if you get to know individual practitioners of public health or clinical medicine, and sometimes they're the same people, often they're not. Again, my impression, which I think is pretty up close and personal, is not of individual failures so much as collective failures. And I don't mean that as a cop-out, Ashish. I know we have to assess accountability for poor performance. But these ideas from social theory about agency, power, and again, how to assess accountability are important. And they lead us right into a second point that I'd make about this is, if it's not, individual failure after individual failure, what is it? And then we have to look at the systems, as you've said before, many times, and how they perform poorly. For example, in Massachusetts, which is a very blessed state in many ways in terms of safety nets, not blessed enough, mind you, but compares favorably to other states. Why do we have so many public health jurisdictions, over 350 of them in Massachusetts alone, which has 6 million people? And of course, I'm comparing that, as you know, to my experience in Rwanda, say, where there are not hundreds of jurisdictions in that country of 12 million people, but national healthcare delivery systems and national healthcare insurance or health insurance systems that have allowed them to coordinate a much more coherent response. So I'm sure we'll get a chance to dip into that, but you knew that I would say, look, we have to look at the social systems, and we also have to look back at history, right? Well, how do we, to go back to your opening formulation, how do we get where we are? And that is another challenge for us analytically. Do we know a lot about the histories of these healthcare delivery and health insurance systems, or do we not know enough? And it's almost always the latter. We just don't, either we don't have the time or the inclination to go back and look at how these systems came to be. And that's going to be an important challenge going forward as we think, how do we want to change them, in what ways, and when are these changes necessarily radical changes, or when do they call for entirely new ways of addressing public goods for public health? And I think we are there. I think I've heard you say this recently as well. I think we're at a point right now where we can start to ask some really hard questions, or continue to pose really difficult questions about how we're going to get out of this mess. And I don't just mean, over the next few months, but how are we going to get out of the mess that's going to be around for a while in this country and in others, and how do we prevent this kind of loss again in our lifetimes?
So let me pick up on a couple of points that you raise and take one step back, which is, so if you and I were here 2 years ago, and let's say we were chatting, and we did chat about 5-6 years ago, we had a long conversation about what had happened in West Africa with Ebola and what the lessons were. But 2 years ago, if you had looked at the Global Health Security Index that was created by the Hopkins folks, really terrific analysts, if you looked at most of the kind of assessments of pandemic preparedness, US tended to be number one, and sometimes share number one or number two with the United Kingdom. But these two countries were seen as the two most prepared for a global pandemic, and largely driven by many of the things you talked about. Great laboratory capacity, fabulous physicians, fabulous public health leaders, great scientists. No one looks at America and the UK as the sort of shining examples of how this has gone. And so I wonder if you can give us a diagnosis of what we got wrong when we were looking at this a couple of years ago through the eyes of structural capacity, doctors per population, nurses per population, laboratory and pharmaceutical company capacity. Seems to me like that was an incomplete picture of how to make the assessment. Help us from your perspective as a physician and as an anthropologist. What's the diagnosis for why we got that so wrong?
Well, I mean, I think that 2 years ago, I would have, I mean, actually, I know that I did point out that this patchwork nature of our public health response, or you know, look at how school districts and various kinds of jurisdictions are all having to formulate their own way of responding to the pandemic in this country, and or a pandemic, and in back 2 years ago, a pandemic of a respiratory pathogen. You know, it was important to signal that that wasn't the whole story, right? Not just the story of do we have the staff, the stuff, the space, but also the systems. Do we have the systems? And that's really, I think, the weakness that we should go to. I also would counsel a really strongly materialist kind of critique of ourselves. Like, you know, you know, you and I have worked in one of the great hospitals in the country, and we know how many ICU beds we have. We know how many nurses we have. And nurses being, of course, the clinical stalwarts of this and many other clinical challenges. But when you look around at the numbers overall, I would imagine, just as the UK compares unfavorably to its neighbors across the channel, particularly Germany, they did have more ICU beds. They were doing more testing early in the pandemic. So I think there were some signs that it would have been okay to say 2 years ago, you know, well, what I said was, I think that Rwanda will do a better job responding to a pandemic than the UK and the United States, because of this more uniform approach, but also because the extent of their investments out of their very meager public treasury is greater than the United States. You know, it's like 20% of their national budgets go into healthcare delivery and public health. We have not been able to point to a single decade in the last 6 or so where the United States has invested heavily in public health. And we certainly didn't think hard enough about upstream factors, you know, the social determinants of health and well-being. So there were lots of cues that there was more to the formula than what was laid out in that excellent report. And then, of course, we all readily turn to the question of leadership. And that can be a cop-out, and, you know, turning to that as some kind of uber explainer of why we've done poorly, but it's an important question nonetheless. And I do think that we have not had good leadership in the first year of the pandemic. We had some great leaders. You know, we both mentioned Tony Fauci as an example, but I think at the level of the executive branch, you know, we've had you know, a disturbing performance. And I think a lot of people in the UK may feel that there's been failures there as well, and in Brazil and in a number of other countries. So I would go for that mix of historical analysis of the social pathologies in which these epidemics are invariably rooted, the social pathologies reflected in an underinvestment in public health and a patchwork care delivery system, the underinvestment in health insurance and other social insurance schemes. And I think, you know, you get a very substantial fraction of the explanation just from that exercise. And notice I did not turn to the things that some anthropologists and social scientists do, and many amateur anthropologists and social scientists, to talk about American libertarianism or, you know, or irritation with rules. You know, I'm sure those are important. But these material questions, these leadership questions, and these investment questions would get us a long way to understanding why we've done poorly. And of course, the main reason for that is to do better the next time around, or for the rest of the pandemic.
Right. Not because we're not done yet. So I thank you for heading me off from becoming or trying to play amateur anthropologist, I was going to ask you about. I wasn't going to sort of
I wasn't doing that, I swear.
no, but I wasn't going to quite go down the road of the American individual, rugged kind of individualism. But I was going to bring up the issue of social cohesion
Yeah.
and this sense of we are in this together. And maybe that's just a different version of asking about American individualism, but it feels maybe a little different than that. There, it has felt at times like a splitting of a country that's struggled to have a kind of a unified vision of where we are and how we move forward and what the challenges are. Do you see social cohesion as a small, medium, or large part, or the lack thereof, I suppose, as a small, medium, or large part of what's going on? Or do you not think that you think that's too easy to focus on and maybe not enough of the.
Oh, I think it's a large part. I'm just saying that it is difficult to assess. And one of the reasons we're in a better position to do that now is because of the ongoing Black Lives matters and other responses to, for example, the killing of George Floyd in the early months of the epidemic. That lays out the degree of the pathology, right? And therefore the lack of social cohesion. So it's not that I don't think we should be going into those arenas to explain our uniquely poor performance. It's that I think we also have some serious material deficiencies that don't always show up in discussions of social cohesion. And again, I focus for a reason on staff, stuff, space, systems, and support, because those are easier and more readily gauged, if you will. Like it's not impossible to know even tomorrow, well, if these are the staff we need, and I mentioned nurses, as I always do first, nurses, physicians. Well, how many community health workers do we have? How many contact tracers? How hard has it been to say, we actually do need to think about contact tracing to get out of this mess?
Yeah.
And that has been more difficult here again than it has been in Rwanda, which is kind of shocking since that's such a poor country. And I do hope that that's going to be over as well. So I'm all for it, for these analyses. And I'm just saying, let's not forget to look at the social and historical roots of these deficiencies, and then to look at how that maps onto a rather chaotic health delivery system and a very, very underfunded public health delivery system. And in that, we would compare unfavorably to many countries, on the public health investments.
Absolutely. Yeah. So I'm gonna ask you to indulge me for one more question, where I stay on this, like, me being the amateur anthropologist here, Paul, and again, and let me just lay this last one out that I've thought about, and that is even in a pandemic, which by definition affects all of us, is pandemic. There has been a theme of othering of, it's really older people who are getting sick. It's really chronically ill people. It's obese people, people who don't take care of themselves. It's really brown and black people. And so there has been this underlying theme as I have seen it, but I wonder, do you agree with that? And is that hampered the will and the ability of our country to rally around? And again, I don't in any way mean to underemphasize. I want to come back to the staff, the stuff, the systems, all of that, which is so critical. But I wonder if I'm overplaying that, or if you feel like there has been that underlying part of this where we certainly did with Ebola, right? It was the other. I wonder if you feel like it played out here in a pandemic that affected all of us so much.
Well, again, I would be hard pressed to point to a single epidemic in the United States, or the pandemics that we've known, which are few in number, thank God, in which precisely this phenomenon wasn't registered early in the course of an epidemic. You can look at plague in San Francisco 100 and some odd years ago, and the othering of Chinese immigrants and Asians in general. You could look at the HIV epidemic in the 80s and the profound othering that went on, and sometimes still does. They all tell a story about how one of the initial moves is to other, is to move people into some category that is other than than we. And so I think that's a really important exercise. And as our mutual friend, the historian Alan Brandt, teaches, is this is really encountered in almost every serious inquiry about the social contours of an epidemic or a pandemic. And these are related to a lot of those material concerns we bring up about staff, space, systems, and support. In the context of othering, post Jim Crow, for example, in the United States, you can also say, okay, how is othering reflected? And you mentioned Black and brown people. How's that reflected in investments in the staff, space, systems, and support that anyone needs to get through serious illness, catastrophic injury, or facing an epidemic that requires you to adopt measures like social distancing? And that too, I think, is a really important exercise, and one that can happen again in the course of an epidemic or a pandemic. The analytic exercise and steer responses. And and sometimes those responses are surprising. Like I wasn't, I was hopeful, but I was still shocked when President George W. Bush launched the President's Emergency Plan for AIDS Relief, which was, in a way, the best countering of the othering that would say, this is what we've discussed as clinical nihilism. Those people are not going to get antiretroviral therapy. And then the list of excuses, some of which come out of conventional public health schools, unfortunately. It's not cost effective, it's not sustainable, it's not feasible, it's not even prudent. So that those formulas for othering have been encountered in any case. I've been at this for a long time, and I've never failed to encounter them or be able to dig them up when they're less than obvious. They're usually quite obvious.
Yeah.
So that's part of the response that we should push forward. When do we see it? What are the costs of that kind of othering? And how do we stamp it out?
And I love, I'm going to come back to your point about HIV and PEPFAR in a second. But I, as you were speaking, the kind of connection that went off in my head that was really powerful is that these issues of whether it's social cohesion, whether it's othering, which are of course deeply related to each other, actually play into staff, system, space support, right? Because if you think the problem is the other, then your motivation for investing in all those things is very different. And I think your point really powerful that while this has happened in this pandemic, right? Our friend Alan Brandt teaches us that this happens almost every time there is a new health challenge. We begin by asking, why is it other people and what have they done wrong to deserve some of this? Because somehow it makes it easier. I wonder if you threw in something, and I'm going to actually ask you to draw it out a bit, Paul, which is the excuses that we often come up with for why we can't do certain things. I remember I was finished training and around the time of PEPFAR, and the conversation about getting antiretrovirals out to the African continent, some of the arguments against it were, in retrospect, borderline shocking, maybe even not in retrospect. But I remember people talked about how, well, these medicines have to be taken every 8 hours and Africans don't have watches, or, just horrible, like ridiculous stuff, guised under well-intentioned. And I will say one of the things that I did find shocking was this sense of, is this a prudent investment? Is this cost effective? If you only had a certain number of dollars, would you really spend it on antiretrovirals? That was a recurring question that came up. I'm going to ask you to not hold back and tell all of us, why do we do that in public Why do we fall into that trap? It feels well-intentioned on some level. And how do we fight against it? Because it's not just about HIV in Africa. It shows up over and over and over. It shows up in how we think about, care for poor people in Providence and Boston, not just over there, but right here in our own community. So why do we do that in public health? And how do we make sure that we resist it?
Well, I won't hold back, I promise. But it's a complex question, right? Because there's a reason that I'm reluctant to attribute uh, any kind of malevolence to some of the folks saying this, because I know them, you know them, we know them. They're colleagues. They're using tools that they've been trained to believe in, and they don't always use them critically. Each of the examples I gave, not cost effective, not feasible, not sustainable, not prudent. These comments and these ways of seeing things all come from paradigms, and they're largely generated by elites, right? So I never heard, as a physician working in Haiti and then Rwanda and then Malawi and Lesotho, et cetera, I never heard anyone, at the hospital or in the clinic who was living with HIV or had a family member affected by it. I never heard anyone say that. I never heard anyone say, I'm a rural Haitian woman and I'm sad to learn I have HIV disease, but it's not cost effective for you to treat me. This came from people who looked and sounded like me, and I should say looked or sounded like me, and who had benefited from the very kind of social protections that would shield them from that kind of logic. So, I think it is not difficult to discern the origins of these logics, even terms like resilience. Where does that come from? How useful is it to describe an individual who's afflicted by COVID or AIDS or any other problem? And then to the other part of the question, like how do we combat that? I think we should be very ecumenical and use as many different ways of defending what is a moral position, by also underlying that there are many other ways to say this is bad logic, not just for these people who are being dismissed as treatable. I mean, we saw headlines in the early days of AIDS that like too poor to treat. That was a Newsweek headline. It may have even been the cover story. But the point is, the logic is so outrageous, but it's also omnipresent. And some of the ways that I would share with the audience about how to fight back, and you said don't hold back, so I think we should fight back. I know you know that. Is here we are in a school of public health. Do we have an idea of public goods for public health? Of course we do, right? And what is a public good for public health? It's safe roads. It's go right through the list. It's insurance of all sorts, as we have not really done well on that topic in this country. There are lots of ways that we agree on public goods for public health. Mask wearing in the face of a respiratory ailment, right? So that's one, but there's also a human rights paradigm, and I go back to that a lot because it's in a way an unanswerable paradigm in a good way, right? Health care should be a human right. And that's not even the same as saying health should be a human right, because it's not clear that anyone other than God can assure that. But health care, oh yeah, we can fight for that as a human right. And then, sometimes when you're talking with an audience, let's say of heads of states or, ministers of finance, and I find myself doing that quite a bit, actually. I wouldn't have seen that when we were back in our salad days at the Brigham, but I'm asked these kind of questions from people in a position to make a big difference. And then sometimes I talk about, look, investing in public health is a way to break the cycle of poverty and disease. And it looks to me that that's one of the arguments that the current administration in Washington is making right now. You want to see economic recovery and then growth, inclusive growth, then we have to stop the pandemic and we have to invest in these safety nets. So, I mean, I think we should all become fluent in the varied paradigms we might muster or draw on in order to defend what are fundamentally probably moral arguments that we should not allow such unequal chances to trash our social cohesion. And I'm certainly not above trying to use all of them. And there are other ways, that come up in the course of conversations and in the course of work. And we're seeing, I think, a lot more of those occasions now than we have, and that's probably due to the pandemic.
Yeah. Let me ask a question from one of the students. Peyton Louise, from a student of global health at Georgetown, asks, and it's both pertinent to what you were saying and an important issue. Peyton asks, the question is, do you believe this pandemic will impact universal healthcare around the globe? And let me just add one more line to that, which is, we did see after the 1918 influenza pandemic into the early 20s, a real movement towards universal health coverage in many countries. How do you think this pandemic is going to influence policy, and will that human rights paradigm of healthcare and access to healthcare and high quality healthcare as a right be taken up by policymakers coming out of a pandemic where the idea of living through a pandemic is bad enough? The idea of living through a pandemic without having coverage is particularly horrendous. How do you see the pandemic influencing universal health coverage around the globe, not just in the US, but also the US?
Well, as I said to you when we were talking about Ebola, I am either necessarily an optimist or congenitally an optimist. So you know what I'm going to say, but I believe it. The question about believing it has to be linked to our agency to make this answer I'm about to offer correct. And I think the answer is yes, we're going to see an impact of this pandemic on universal healthcare aspirations and universalisms of varied sorts, right? Social protection, as I mentioned. And it's going to be a positive impact because these kinds of disruptive and indeed terrible calamities are often chances for people to think about new paradigms for social protection. I mean, the depression is often lifted up. So are conflicts and wars, and certainly pandemics, or the earthquake in Haiti in 2010. The impacts might not be what we would like them to be, but they often allow us a space, an opening, in which to push forward long cherished goals. That's what's happening in the United States, right under our noses now. If this is going to succeed, which it must, then the agency questions should come to the fore. Everybody listening to this, or the students, faculty, deans of schools of public health and medicine, for example, what is going to be? Are we going to really retreat again to saying, well, it's not sure that this is feasible, sustainable, cost effective? Those are just tools to help you choose between different options to promote the same goal. That's what they should be, right? And today is the anniversary of the genocide against the Tutsi in Rwanda, and of course, it would be difficult to imagine a deeper and more fiery hell than Rwanda in 1994. But look at Rwanda now, and what made the turnaround happen. In part, it was the dimensions of the calamity and loss, and the idea that we need to rethink, everything in terms of governance, in terms of healthcare delivery, in terms of education. And part of the peacemaking that came after the genocide against the Tutsi was for the leadership to say, we're going to focus a lot on healthcare and education because inclusion is critical to our success and to avoiding any recurrence of these calamities. And, again, I think it's possible for all of us to point to some cataclysm, whether we have any personal experience or not of it, and say this led to something, some progress. And I think that's where we are now. I know I've said that twice already, but to make that come to pass and be true, is going to require a lot of engagement from a lot more of the citizenry than is usually engaged in many, and not just in the United States. I'm talking about degrees of participation in these processes. They tend to look like what's happening here. You have colossal obstructionism in Congress, say, but you can look and see how many Americans favor some of these interventions, including national health insurance programs, including unemployment insurance, et cetera, et cetera. A number of interventions that are routinely disparaged or even worse, blocked by obstructionists. That's not really what the population's views on this, the citizenry's views, or beyond citizen, people living on this continent, they have a different view of this than some of the people who make those decisions. So when we're lucky enough to have enlightened leaders, great, because then they'll be echoing the will of many, and particularly many that has been shut out. But if we don't have their endorsement, we need to push for it, or find other leaders who can more accurately represent these very, very common aspirations for protection from this kind of harm we've experienced the last year.
Yeah. No, it is undoubtedly true. I mean, a vast majority of Americans, even before the pandemic and certainly after the pandemic, I think, and during the pandemic, but even before, vast majority supported the idea of universal protection, universal coverage, making sure that people had coverage for basic health services. I want to shift gears a little bit and talk about health security. One of the frameworks going into this pandemic was this idea of we should invest in these issues because it's a national security priority. And that certainly is getting revived again in a very substantial way, where I see the securitization of global health as a way to protect Americans, which is a very perfectly noble goal for our security industry to do. I mean, I have no problems with that. But what do you think are the risks of turning global health and turning engagement in health and well-being of people around the world into a security exercise? And are there any upsides? But I want to start with the downsides, the challenges, the things that would worry you about them.
Well, I mean, you notice, Ashish, that I did not mention that paradigm in the three that I advanced, which were human rights paradigms, public goods for public health, and economic development or recovery. In many ways, in most ways, I would say those are all safer paradigms than a health security paradigm. If the paradigm is really about the security of the species, the humans, it makes me a lot less uncomfortable. But nationalism is I don't know. It's not the appealing way to move this forward, in my view. In any way, I'm just saying I have declined to get enthusiastic about that over decades, because it happens again and again. And as you point out, it is the job of elected officials to protect the American people. It is the job of elected officials in Rwanda to protect the American people. But what strikes me as someone who started medical school in 1984 is that, and has since worked, in thinking about people who are not protected, even when there are national security regimes out there that would protect some, is that fear and circling the wagons mentality, whether these are nation states or just states or communities, that doesn't seem to be what motivates most of the patients or students or colleagues that I've worked with over the last 3 or 4 decades. It's much more likely to be fellow feeling, kindness, even love of one's fellow man and woman and child. And I think that the cost of global security or health security paradigms can be high. Now, again, as you just said, there are some folks whose job it is to do that, to think in precisely those terms. And often their work doesn't rankle me. It is headed in the same direction sometimes, which is towards less or fewer assaults on our well-being. But I just don't think, I think it gets overblown even as one of several competing paradigms. And it's not the one that, look in a community that's been hard hit by COVID. Um, I'm lucky enough to be joining a group of colleagues in Pima County, Arizona this afternoon, including the health commissioner who worked with us in Sierra Leone on the Ebola response. And I was reading her language about this and her looking at her slides for her presentation. And it's got nothing about, let's make sure and ward off the incoming threats into Pima County. It's really about solidarity, inclusion, addressing exclusion, and keeping people safe through participation uh, in public health, and making sure that others, maybe everyone, could participate. So I'm just saying, it's not something I bump into all the time in my clinical work or teaching, whether in Haiti, Rwanda, Boston, wherever. I think there are better angels of our nature that we can draw on with more effect to that point. I mentioned PEPFAR. Some folks try to justify that as a health security intervention, but that's not really what we heard in the launch of the program or what we saw. Again, some of the folks are saying, hey, if we don't deal with AIDS in Africa, they're going to be showing up on our doorsteps 15-year-olds with AK-47s. You literally heard that. I know I did too. And again, sometimes from colleagues and friends. But that's not what underpinned that massive program. It was much more about compassion and fellow feeling. And if that administration could do it, well, then this one can too, just to stick with the United States. And I think we will get more mileage out of that approach. Of course, people want to be kept safe. Of course, they want to be spared this kind of risk. But there are other ways to do that. And I just mentioned 3 other paradigms that are equally at hand, and I think more powerful in many ways.
And one of the points you made right now, which I've heard you make at other times that we have spent time together, is the importance of trust, the importance of solidarity, in a sense that people need to feel respected and cared for if they're going to engage on things. And the idea that you show up and you say, hey, it's for collective security that you need to do X. I mean, talk about things that are not going to engage people and things that are not going to be effective in the long run, even if you can make it work in the short run. Just it's not sustainable in any way. And that, I think, has been a really powerful lesson I've learned from you. I'm going to ask one more question on this issue, and then there's a bunch of stuff from students and others asking. But let me ask you about vaccinations, where we are in the world, and how we shift. And I will be honest with you, Paul. There are times when I've fallen into this trap as well, and I worry about it. So let me just lay out the issue and the trap that I feel like I've fallen in. And at moments, I literally think, what would Paul Farmer say if he was seeing my tweets on this? And then so I'm going to ask you what Paul Farmer might say. We've vaccinated about 40% of adults in the US. There are 20-year-olds, 30-year-olds getting vaccinated in the United States. And I don't begrudge that. I think it's fantastic. And I want to see everybody vaccinated. Healthcare workers in large parts of the world have still not been vaccinated. Elderly people have not. In fact, a majority of countries have barely begun vaccinating at all. And this inequity that we know of, and we're not surprised to see, is more stark than even maybe I expected. I think it's even more surprising and stark than I expected. And at times, Paul, and this is a little bit of a confession, in my zeal and my desire to get Americans and the American policymakers to focus on a global strategy, I talk about how we're all in this together, which I think we are. It's a global pandemic. But it is very tempting to say that we ought to do it because it makes us safer. Mm. And I worry about that argument because it starts skating right to the edge of something that I don't love. And that's where I start wondering, what would Paul Farmer say about this? How do we make the compelling case that we have got to lead in the world on global vaccinations? Are you surprised by the stark inequities? And do you worry about the arguments that I sometimes find myself tempted to make because I feel a sense of desperation to get people more motivated?
This, Ashish, is a guilty smile because I've said it too. You know, if you say, we're not safe until everybody's safe, that easily lends itself. And I've said that, and I know you have too. I've heard you say it. And that, as you said, we should worry that that's not an adequate, you know, reason to do this work. There are all of the other reasons. I already fessed up that I'm more of a species person than a nationalist. I would add that that's what Pope Francis tells Catholics they should be, which is on the side of humanity. And I am. I have nothing against the bats or the pangolins, mind you. I'm all
Yeah.
for them too. But this is, I think, at least I hope you will forgive me for having said that as well. Um, it's probably not even true immunologically, but there are reasons to worry, as you know, and you've been talking about it, about these new variants, and whether or not ongoing mutation because of community-based transmission is going to render some of these vaccines much less effective. That already seems to be the case, as you know better than I do. So I think there are also epidemiological reasons to push for vaccine equity. And just think about every well, we only have really one story of eradication, smallpox, for the creatures, the ungulates. We have rinderpest, we're told, but polio is nearing its end game, and of course the end game of smallpox and of polio are instructive in this regard, right? Because they showed that it was very difficult to achieve herd immunity, even though with the case of smallpox, there was a safe and effective vaccine and no non-human reservoir. So I think we should be not too tough on ourselves about having indulged in that. Well, let's call it health security adjacent commentary.
Adjacent, yes.
But let's keep going back to public goods for public health, to a human rights paradigm, and to arguing quite authentically, I think, that if you want to break that cycle of poverty and disease, whether in the United States or Rwanda, then investing in public health, and in this case in the vaccines, and their local production, I believe, is essential. Anyway, that's what we're hoping might happen in Rwanda. Again, I'm not authorized to comment on how likely it may come to pass, but I can tell you I would love to see mRNA production happen on that continent. And if we don't, and there is a need for regular booster shots, I mean, really, we're going to have the same arguments about exporting, 500 million, a billion doses every year. There are better ways to do this. And they also address a lot of these other issues that were brought up or are brought up in a human rights paradigm, right? Shouldn't people on that continent have the right to control their destiny with local vaccine production, and in fact control their engagement in markets for vaccines, et cetera?
Yeah.
So I just want you to know, as Pope Francis would say, you are forgiven for, and let's hope I am too. That wasn't blasphemy, by the way. I really am, Catholic.
No, I think that was really good. Several questions have come up that I want to ask. Andy Barnes, Jazz Aluwalia, and others have been asking about your advice to public health students at this exact moment. Obviously, we're at a public health school here. We've got a lot of deans and a lot of students from other public health schools joining us today. It is a remarkable moment to be in public health. It is also interesting to me as a physician, and I wonder if you see this, the sheer level of interest and engagement in public health among physicians and nurses and other care providers who and really starts making you think about what that relationship between medical schools and schools of public health should be. But we can come back to that at another point. But advice, guidance for students of public health, whether they are at a public health school or at a medical school or a nursing school, about how they should see their career as people in a field that is got a huge spotlight on it right now.
Well, first of all, you told me not to hold back. Sometimes I wonder if we haven't tarnished the notion or the term really of public health so much through past errors and ongoing errors that it might be better just to think in terms of global health equity. And we've had a chance to discuss this already, so forgive me. But that's the reason that my colleagues in Rwanda and at Partners in Health ended up, when we launched a new university to train health professionals in Rwanda, we called it the University of Global Health Equity. It was to lay down not a stake of uniqueness, or do you lay down a stake, or you pound in a stake, whatever. It wasn't trying to be unique so much as saying, the Rwandans taught us how important it is to focus on equity. And I think the United States is very ripe for that kind of transformation. And it's not just the delivery part. I mean, the basic science of public health, epidemiology, other, health economics, focusing on equity or questions of equity has a high rate of yield, and it matches the aspirations of the students. Right? Yeah. So, when we were, or I'm a little bit older than you, but when I was a student in the era of international health, first of all, it was very unusual for medical students to even take public health classes. Even though it required walking all of 200 yards across a courtyard between Harvard Medical School and Harvard School of Public Health. That's another problem, by the way. Too few medical students or nursing students get to take public health courses, and we all should be fluent in that, or literate at least. So I think global health equity, or some other term that really makes it clear that we're focusing on redressing disparities, is important to move front and center in public health. And some people say, well, it used to be front and center. It's true. I mean, John Snow made it front and center. But something happened in the mid 20th century where there was a sort of retreat from this logic, I think. And again, not in the student body and not in the many of the practitioners, but it just wasn't as front and center. And another thing I would say is, and this is hard to say, I have encountered again and again, not so much among students, but among some of my peers in public health, a kind of irritation about being the underdog all the time. Back to Alan Brandt, he's written about this. He said, there's been a lot of tension between medicine and public health, and sometimes it escalates to outright war. That's from some scholarly piece he wrote that, and I've seen that again and again, and many of those listening have as well. It's not the public health people who are the underdogs. There are real underdogs out there who are being neglected and need to be the focus of our attention, which should be global health equity. So those are two things that I try to work up the courage to say to students, if they don't say it to me, because many of them believe that already. And I just, to give one example to make it vivid, because I feel like I've been talking on what might be confused as an abstract level when I don't mean anything abstract at all. I had a friend, an American, an infectious disease doctor, who fell terribly ill with Ebola, back at the time that we were talking, or maybe a little bit earlier. And he survived because he was airlifted to the one thing he needed, which he could not get in Sierra Leone, which was critical care. Supportive care, he could barely get. And if he did get supportive care in Sierra Leone, it's probably because he's a white guy. Because this is at a time when some of our peers were saying the treatment for Ebola is always oral rehydration salts. And we'd be saying, well, what if they're vomiting? What if they're in a coma? What if they're obtunded? So there was all these awful things going on right then. But he happily survived because he was airlifted to Emory University. And, I was in West Africa then. And, what I heard there was, oh my God, we need that kind of care too. We need supportive and critical care, and this from nurses and doctors who were falling ill. And I swear to you, I heard many of my public health friends and peers saying, imagine if the resources invested in saving the life of that doctor were invested in prevention here in West Africa. And I would finally say, but that's not at all what our West African colleagues are saying. They're saying, imagine if the resources invested in his care were invested in our care when we fell ill. So even there, you see again and again this grumpiness between medicine and public health, which I think, again, takes the focus off the people who should be the beneficiaries of both medical and public health interventions. And I think students should be aware of it and not just be so quick to say, well, we're screwed. No, public health has been underfunded, but that's not the same as you, a practitioner of public health, and I count myself as one of them, being screwed over. So I think these are traps that are all over our work, and why global health equity, again, along with historical analysis and understanding, that Providence, Rhode Island is on the globe too. If we can really shift a little bit towards militants, not about ourselves and our own standing, but about the work that we're doing together to improve health or to prevent illness, that would be a great thing to see in American schools of public health and medicine.
We're almost at time. There's a bunch of questions, but I'm going to finish off.
Hey, we just started.
Paul, I told you we could do I could do this for hours, and we have, but we do have to draw this to a close. But let me ask you really just to reflect. So here we are in the US. We are turning the corner, a phrase our previous president used too often and pretty consistently inaccurately, but we are turning the corner on the pandemic as it affects us here. But how do you see the pandemic shifting our understanding of global health? And let me frame it maybe just in the following way, Paul. Even though we call it global health, there's still been a bit of an international health mindset of global health is about what happens over there.
Yeah.
And it strikes me that the big challenges of the 21st century, whether it's pandemics, climate change, a whole bunch of other things, it's very hard to separate us and them and over there and over here. But to not get too close to that security line of the reason to do this is, are you optimistic about where global health goes after this pandemic? There has been a long-term shift towards more solidarity, more focus on equity, less focus on colonialism. Do you feel like this pandemic accelerates that shift in a good way? And help us think about where all of this goes over the next 5-10 years and in this field, and how optimistic are you that we can get there?
Well, I would just say, in addition to being more appalled than I have been in, my adult life by what has happened. I mean, I've lost friends, family members, patients. Members of my family also lost their jobs. This is something that we haven't really experienced as a collective, and it's pandemics that can sometimes do it. It's not that nobody is spared. Plenty of people are spared, and plenty of people are subjected to really outrageous risk. But there's more awareness of it. And maybe again, I'll go back to being my eternally optimistic or congenitally optimistic self. If more people are aware of the nature of, of the need for pragmatic solidarity, just so that doesn't sound too highfalutin, pragmatic solidarity when you're doing contact tracing and you're asking someone to isolate for 2 weeks or 10 days or whatever, where's their food going to come from? Who's going to visit them? Who's going to take up the task that they had, either taking care of family or delivering food or whatever it may have been that they were doing, right? Or a healthcare provider. I think that this raw nerve awareness is one of the only good things to that we can point to affectively, that a lot of people are aware of things that they were not aware before. And again, epidemics do that. And just to go back to colonialism for a second, When we talk about decolonizing global health, um, it's important to look back at colonial medicine, at least on the continent that I, have lived in and worked on for a while, or two of them, this one and Africa. Uh, it's kind of shocking to read the details, and again, to follow our friends who are medical historians, and you see that so much of the investments made from the late 19th century into the 20th century, they were focused on disease control and not on caregiving. And so this control over care model was typical of colonial medicine, probably everywhere, but certainly on that continent. So it never had, the staff, stuff, space, systems, and support required for those who were sick or injured, ever. And I'm not an expert on colonial medicine, but I think I could stand by that from some of the research and that anybody could do by reading the social historians who do know. So control over care is the primary pathology of public health in the world today, not just there, but here. And we need to break that paradigm. We need to smash it right apart because people are looking when they're ill or injured for care. That's why if there are no professional caregivers, like in some of the places I've worked, they go to traditional healers and their family members. Humans do this wonderful thing of caregiving, and public health should be caregiving. And the first, in the first cohort of, don't worry, Ashish, I see you looking at your watch. In the first cohort of the contact tracers that we were trying to work with and train and learn from in Massachusetts, I got a chance to address them, like in the first day or so. And I said, just keep saying to people, I got you. This is a part of our caregiving. We're going to think about the food that you need, or who's going to pay your cell phone bill, or you're preventing your eviction. This is pragmatic. That's pragmatic solidarity, and it's caregiving. And I think, going forward to decolonize global health in this country and in others, we need to keep going back to that material roster as well, staff, space, systems, and support. Because I hear that again and again from my patients, from community health workers, from those who have not benefited from, the kind of good fortune that I've had and you've had.
Yeah.
And making sure they could benefit from that is a really important part of this work. So I'm optimistic because I know we can do this better and can do it more.
Well, what better way to bring this to a close? To remind people that at the end of the day, it really is about caring, and it's about caring over control. And can't help but remember that, is it a Paul Dudley White? I can remember who has that thing, that the art of, the secret to caring for the patient is to care for the patient.
Francis Peabody?
Oh, is it Peabody? Was it Francis Peabody?
Well, it would be delightful if I was right, but
yeah, it could be. I think you might be right. But that is a motto for public health as well, is that the art, or the secret to caring for people is to care for people. Paul Farmer, thank you, sir. This was delightful. Could not have asked for a better conversation, and I am deeply grateful for your time, for your mentorship and friendship, and for your leadership in public health. We all benefit from it every day. So, Paul, thank you so much for being with us.
Thank you, Ashish. And I'll just say it one last time. I can't wait to get back to Brown. Thank you.
I look forward to it. All right. Bye, everybody.